So today we have myself, Dr. Kyle Paxton, and Dr. Ryan Foley here, as you guys know, and then our esteemed guest, Dr. Erson Religioso here. So I'll give a little bit of background on him, and then I'll let him fill in. But he's a fellowship trained cash-based PT. He owns a practice called Edge Rehab and Sports Science in Buffalo, New York. It's good to have another Western New Yorker on here. That's where I'm from. I'm from Rochester, actually. And then he owns a really, really awesome continuing education company called Modern Manual Therapy, the Eclectic Approach, which is now expanded into even more than just manual therapy stuff. He's got modern strength training, modern patient education, all kinds of branches of things off it. He also owns a line of manual therapy, mobility, fitness, and strength products called the Edge Mobility System, which is really, really cool stuff. I think one of the reasons we all vibed initially was because you do a really great job of bridging the gap between the nervous system and kind of more of a traditional biomechanical approach. So I think all of those things are going to get talked about today. Anything else you want to add? I know you're doing faculty stuff at PT schools. You have more letters after your name than anyone could ever imagine, I think. But fill in the gaps if I missed anything.
I have a podcast, Untold Physio Stories podcast. It's perfect
There
for
you
a
go.
commute if you still have to be commuting and not working virtually and seeing all virtual patients like I've transitioned to. So that's Untold Physio Stories. You can check out all my stuff. Modern Manual. Follow me at Modern Manual Therapy on Instagram, Facebook, and YouTube. So I think you pretty much hit all the highlights. Thanks, Kyle.
There you go. Yeah, no, that's great. We're excited to have you. And I know we're going to kind of try to keep things pretty casual today and just have a discussion about all things nervous system and movement and manual therapy and things like that. Ryan, did you have anything you wanted to get us started with, or I know you and Erson have some background as well, known each other
Yeah,
for
yeah.
a while.
I mean, we were all in PT school. We were all following Erson's work all the way through in the fifth and sixth year. It's the stage of the late stage of DPT school. And Erson, that your first courses that I took at a PT school.
I'm sorry, Ryan.
Ryan,
You broke. Yeah, you broke up for like until all I heard was PT school. I heard you followed me, and then I heard something about PT school, and then everything in between.
Yeah, everything in between was gone. But yeah,
Yeah.
I was going to say that your course in Soul PT, I think it was up in Boston, right? With Andy
Yes.
and the guys. I think even John Russon was there as well. That was the first course, one of the first courses that I took at a PT school. And I think what drew me an awful lot to your approach was your ability to draw in so many different concepts, so many different modalities, but to create your own framework with it as well. And that's something that I think even after your course, a lot of the courses that I took after that didn't really tie the techniques, the strategies, however you want to put it, into an actual framework that you can use to kind of guide your way through an assessment, through a treatment as well. It was almost like, okay, this is that, use this technique, this is that, use that technique. But in your case, it was more so about understanding when to use certain strategies. And so did that take an awful long time for you to develop that framework? I know you have a lot of different approaches, different courses that have led to the creation of your own framework. But if you wanted to share more about that, what led to that framework?
Right, it did. Like Kyle said, I'm classically trained as a manual therapy fellow, and back in 1998, 99, when I started my fellowship and my residency, there was no kind of difference at the time. It was very pathoanatomically basis. I learned 300 different ways to palpate and feel the minutia of I convinced myself that I could feel the millimeters of difference in gapping of zygapophyseal joints in between spinous processes. And, eventually I figured, hey, you know what? I think I finally got Gillet's test, which is like the worst. I always call it's like the worst SI test ever, like the Stork test or the step test, whatever you guys want to call it. One of the worst tests ever, second only to probably like Rouge test. I hate all those tests, right? But yeah, like many manual therapists, I practiced the suggested 10,000 hours until I thought that I got it, but really just convincing yourself that you feel something. And then, you get into this feedback loop of, well, I think I felt it. So, but I got it moving and then they felt better. So therefore the assessment must have been valid. And, that is probably, unfortunately, still taught. So like many things, manual therapy, particularly joint and thrust manipulation, didn't get all the results that I wanted. So I started to look into other things like soft tissue work and neurodynamics. And then again, like most courses, you learn new techniques, you learn fancy new assessments, you go back, your outcomes initially improve, and then they kind of like go back to whatever kind of status quo that you get into that makes you feel like, oh, I must be missing something, because you're going to have these patients that you're going to not do as well as you thought, and you throw the kitchen sink at them, and for some reason they still don't get better. So in my quest to kind of replace all the gurus that I learned from, I wanted to get as many credentials after my name as possible. So that's what leads me to having that alphabet soup after my name. It was an ego thing, as much as it was a knowledge thing back then. And I started taking the McKenzie courses, and I remember telling the instructor on the very first day, I'm only taking these courses and getting certified because I want the letters. I'm never even going to use this. Like, how arrogant, right? I can't believe that I said that. Then she picked on me, rightfully so, the rest of the time. And she should have, because I was too cocky. But then, combining all those disparate approaches, especially like an MDT or McKenzie framework that focuses on patient-generated forces and patient education and patient empowerment, with all the stuff I learned from University of St. Augustine, which was like, you finally get around to looking at movement at step 15 of like a 22-step evaluation, which is crazy. If any of you guys are University of St. Augustine grads, I hear they're still teaching it. That's nuts. I mean, anything that's that complex, it probably shouldn't be part of your repertoire. I mean, I think complexity initially attracted me, but I realized that when you go back from a traditional manual therapy course, you really don't know what to do on Monday. So I had to put all these things together, right? And eventually I kind of just synthesized my own algorithm. And I once tried to draw out what I did in my head in a simple like algorithm with colored boxes and arrows and everything. And when it took up like 5 pages on Google Docs or Word or whatever I was using back then, it had too many arrows. I realized this probably isn't something that I could teach. So I just kept, every year I kept on teaching and teaching manual therapy courses, and I kept on stripping off more and more assessments and more treatments. And when I first took my first pain science course with Butler, I thought, oh, this stuff is great, but it's only for people in chronic pain, as opposed to everybody. And then, patient after patient after patient, I realized that I was missing something. And ultimately, it came down to me having what I thought was a locked facet. So I was probably about maybe 8 or 9 years into my career, and I was taking a McKenzie Clinical Skills Update course, and I woke up, and my wife is a PT. She tried to help me. So I woke up and I was like, oh man, my neck is really, really stiff. And funny enough, the mechanism of injury was the mechanism that I always told patients doesn't exist. Like it was actually a breeze blowing on my neck all night. Because the first time I heard someone say that, I was like maybe 2 months out of PT school, and they're like, oh yeah, I think my neck went out of place because of a draft. I'm like, yeah. That doesn't happen. I'm like, what would a draft do to your neck? I mean, like maybe a manipulation or like getting hit might knock something out of place, but like if your spine is so fragile that a draft makes a vertebrae sublux or something, then that's pretty. I mean, before even pain science, I thought that was kind of ridiculous. But anyway, air conditioning was broken, and even in Western New York, it does get hot in the summer. So I was actually sleeping on my back with a fan blowing on the side of my neck all night, and for whatever reason, my neck was locked up. Right. So my wife's like, oh, close your eyes. Let me see if you deviate to one side when you extend. So I flex. I'm like, oh, it's pretty painful. When I extended, I'm like, oh, am I deviating? I'm like deviating so much to one side. So she tries to mobilize me. I'm like, oh, try to manipulate it. She's not very comfortable with it. She doesn't like thrust manipulation to perform. She doesn't like to do it herself. And if I went to the clinic that day, I just would have had a couple of fellows that I worked with manipulate me, and I would have probably been done with it. But instead, I was going to a McKenzie Clinical Skills Update course. And if you guys know anything about that, all you do, there's no more learning. It's like only if you're for certified clinicians, and all you do is you watch the faculty treat live patients. So the only thing I'm watching people do is like just end range load all day, all day, all day. I'm pretty much only taking it for CUs. And I'm asking people there, I'm like, hey man, can you manipulate my neck? I'm like some kind of like crack addict, right? Like literally addicted to the crack of a manipulation. Everyone's like, no, just do it yourself, because everyone there is certified, right? So I just start loading and loading and loading. And what started off as like a 7 out of 10 at rest and a 9 out of 10 with very limited range, after a couple hours, it ended up being a 5. By lunchtime it was a 3. And I had maybe done like 300 to 400 end range loading to that same side. And by the end of the day, it was a 0, and I was like getting really impatient. I started adding isometrics. I started doing resistance through the range, and a lot of stuff I teach during my courses to kind of enhance a repeated end range loading strategy. By the end of the day, I was like, oh, there's really something to this approach. So that got me thinking that the whole reason why people get better faster, well, one, that everyone can self-treat, and two, it doesn't have to be some kind of complex thing, doesn't have to have stabilization. It could just be a really simple end range loading strategy that can be performed at a high dosage. So that's when I started actually incorporating that into every treatment. And then it became like the hallmark of my approach is to teach, like, I don't care what the patient is, what the treatment is that you do in the clinic. I only care what you teach the patient and how you present their condition to them. So that's kind of like a roundabout way of how I started incorporating pain science and the McKenzie approach into my approach. But I don't teach McKenzie, just so you know, because I've gotten cease and desist before. So I only teach McKenzie-like concepts.
Yeah. That's brilliant though, because you recognized the complexity of the human system, and you realize that, look, from our standpoint as well, we always look at general principles first. It's not a case where the brain controls the body by looking at precise joint angles, by looking at activating individual muscles and isolated muscles, but it's about understanding general principles of movement control. And that's why I loved your approach, because you put a lot of emphasis on looking at directional movement. So like when someone's looking at neck extension or neck flexion, you could pick on little muscles that might be tight, like short or long sort of situations, or you can look at the directions that they move into. And then for you, that's giving you an insight into where they like to load, where they don't like to load. And then that gives us an insight into what the nervous system might need to reestablish some sharing of load, to potentially have an influence on the need for pain. And it's something as simple as that, like looking at extension, and Kyle will back me up on this as well. When you're looking at those assessments, or when you're going through those assessments in DPT school, you don't even know what you're looking for. You're looking at neck extension, you don't even know what you're looking for. You're just going through the motions, and then you take that into the clinical environment as well when you're actually working. But what you did is you gave it some meaning, so you're not just looking at it as a range of motion, but actually look at it from a standpoint of, and it's almost like a coordination test. How is the system actually maintaining that sagittal plane when they move into extension? Are they deviating to one way? Are they deviating the other way? And then how can we use this to guide our loading strategies? So that's what I loved about your approach, because it actually guides what you're going to do next, instead of just looking at it and saying, okay, let's go on to the next test, the next special test, the next, all this stuff. But right there and then you have an entry point, the treatment straight away.
Right. Yeah. I mean, and again, I got a lot of that from the McKenzie approach, where they would do typically, 10 protrusions, 10 flexions, 10 retractions, 10 extensions, and load many different directions. And I just kind of took all the shortcuts. And initially when I started teaching, I would just say, well, 8 out of 10, if you have some kind of unilateral upper quarter problem, they're probably going to just respond to, retraction and side bending to the same side to reset that area. And I just call it reset, because you're changing a neurotag, you're changing a perception of a threat or stretch rather than actually changing something physical. So when I was only teaching 1-day courses, I would just pretty much go right to the treatment, knowing that the majority of people are going to respond just based on my all my articles that I wrote from the Journal of Anecdotal Evidence, which is what I call my journal, because people are always like, where's the evidence in that? I'm like, well, I have a lot of experience, but I don't have the resources to study this stuff myself. But anyway, when I started developing 2-day courses and now 2.5 day, because like half of it is online, I realized that people probably needed to know more than just, if anyone has all these things, just try this. So that's when I started introducing what I call the clinical practice patterns, that if someone has unilateral upper quarter problems, you assess for this and this. And if they have these things, then you immediately, the assessments pretty much become the reset. Then you can you can add on different things like needling or manual therapy or tissue work or thrust manipulation, whatever you want to do to kind of enhance it, but you always kind of bring it back to that same loading strategy, which is going to make people better. So very few people kind of get the actual meat and potatoes, because, people go to a course just like how I'm sure they go to your courses. What would you say, like the percentage of, other than you guys who are listening, what percentage of people who you teach live really get it, would you say? Like everything that you're trying to come across.
Yeah, I think it takes time. I think it takes time for people, which is why actually our switch to the online version that we have now, I think has been really helpful, because it's stripped out over 8 weeks, rather than trying to squeeze it into 2 days, because everything's going to make way more sense in your head when you're teaching it than it does. And you're like, oh my gosh, this is such a simple concept. Why is it so challenging to grasp? And I think that's something that we've really honed in on over time here as we've done more and more courses, because it is hard. I mean, we get a lot of people who leave and they're like, hey, I have this now in the clinic, like how do I apply it? And they lose a lot of it, which is why having some of the follow-up Facebook groups and things like that. But we really want to make sure you can leave with a couple big points. I think that's the biggest thing for us. And then all the stuff nitty gritty in between, we can start to fill in the gaps afterwards. But that's why I think Ryan hinted so much at the importance to have a framework, and less about all the complexity of the little tiny techniques here and there. It's about, okay, here are the big pieces, and knowing if someone has this, this, and this, you go this direction, rather than all these crazy fancy techniques that are only applicable in very specific situations. I think that's where both of us are trying to go, but it is really hard. And I think that's one of the benefits of COVID. Honestly, it's forced a lot of people to have resources that they can go back to, which hopefully has helped everyone learn as much as we like to be in person. Because I know you said you've added an online portion now, and I think all of that stuff helps as a whole.
Yeah, absolutely. Well, the online was pretty much, it was only lecture, because I just didn't want to take up, like, if you're just going to sit there and watch me speak, and I'm going to lose you half, I'm going to lose half of you after like an hour. Why not just make it online and make it mandatory? And, I hope that they watch it. I mean, I have like so many people who are like, yeah, I listened to it on the way here with my spouse in the car. I'm like, man, I feel bad for your spouse. You just like listen to my 3.5 hour lecture and like the way here. That stinks for them. But yeah, I love the online learning too. I mean, I think my online learning program did well. My mastery program, which is now, it used to be 8 weeks, now it's 12 weeks. It did better before COVID. And I think that people just, I don't know if people aren't used to, or they didn't want to commit to something in like a time of uncertainty, but yeah, they end up getting it a lot better, because over a weekend course, I mean, you only have everyone in the class and their dysfunction to kind of practice on, and whatever issues they have. And naturally everyone just thinks, oh, the same home runs I get here, does it really apply to people who have long-standing problems? And usually it does, because that's the whole thing, right? And I'm sure you guys have found it too. Like, most people can fall into that, what I call a rapid responder category, but everyone's really looking for that last like 15 to 20% that is very difficult. And that's not something that any course is going to ever make easy for you.
Yeah, absolutely. It's always the case on the in-person courses where, the people that are going to get it are the people that have been following you for a while and are doing similar things in their own practice. So they can start to integrate that very quickly into their own approach. But you mentioned something there that I was going to ask you about as well, that you spoke about in the course in Boston, about this differentiation between a rapid responder and a slow responder. And I think that's a nice way to look at it as well, because it just helps to guide what might need to be done throughout the treatment process. And can you give the listeners an idea of what you mean by rapid responder versus a slow responder? I think it makes a lot of sense just when you think about it generally, but some details I'm sure that need to be ironed out that you can definitely help them understand.
Sure. There are a lot of different what I call commercial-based models, and I kind of get that from my buddy Charlie Weingroff, who's a PT and strength coach. And they all have very similar categories. Like McKenzie would call them derangement and dysfunction. Derangement originally meaning that something was out of place. And once you repeatedly unrange load a disc, you could, reduce a disc protrusion, or you can reduce a derangement like a TMJ derangement or a knee derangement. So even if there's not like a meniscus or a disc to actually reduce, or a facet to kind of put back into place, you're still going to reduce the derangement, meaning that they are going to respond rapidly, typically within the first 4 to 6 visits or so. Most people are going to have dramatically increased mobility, pain, general outlook on life, function, whatever. The majority of the majority of patients fall into that category in the McKenzie system. Maitland has similar things like highly reactive, or I forget exactly what it is because I've never taken a Maitland course, but a lot of the courses have, again, commercial-based models. They have categories of patients, and usually ones are easier to treat. But essentially, when I started to look more into how McKenzie fit into something like the clinical prediction rules, which were very popular, say like 10 years ago, for spinal manipulation, a study showed that people who fit the clinical prediction rules for lumbar spine, cervical spine, they also responded well to end range repeated loading, meaning that it's not really that if someone fits these categories that you have to manipulate them, but they're like the patients that we all want, right? They have, it's typically acute. It's there's no hard neuroscience. They may have a little stiffness in one direction, but not all directions. And I think most importantly, they have low fear avoidance, which is key. And they also, in the case of the cervical spine, they may have like an affinity or a positive past relationship with spinal manipulation. So they have like that whole placebo effect kind of going in there. So those are the majority of the people that will probably walk into your door, right? Even if they say they have chronic pain, very few people have persistent chronic pain, meaning that they have pain for, say, they might have pain for years, but it's probably like a bunch of flare-ups as opposed to true persistent centrally sensitized pain like fibromyalgia, chronic whiplash. A small percentage, unless you particularly work in that population, are truly centrally sensitized and cannot be reset easily, regardless of how long people have had pain. A couple of other studies done by Chad Cook, multi-center trials over the course of a year, people have had pain for maybe between 6 and 12 months on average. The majority of them still got better regardless of the treatment, as long as the treatment had some sort of education, strength, manual therapy if needed, and a home program. So as long as they could qualify that they're going to get whatever they defined as good therapy, but not like a specific plan, like it has to be a McKenzie or it has to be mobilization plus stabilization plus patient education. It didn't have to be so regimented. The multi-center trial still found that the majority of people, regardless of how long they've had pain, I think something like 70 to 80% of them may have had pain for more than 6 to 12 months. That just showed what we all kind of know, we've all known. If anytime you've hit a home run, it doesn't really matter how long the patient's had pain, that the majority of patients still fall into a rapid responder category. And I only call them rapid responders because I don't want to put that nocebo in someone's head of saying, oh, you're deranged, or you have this disc herniation, or you have this, this facet that's locked out, or you're a weak core, something that's pathoanatomical, and they can go on Dr. Google and feel really bad about themselves and feed into a negative feedback loop. So, the rapid responders typically identify as having a moderate to major loss of range in one plane. They're typically acute to subacute, or if they're chronic, they have mostly exacerbations that come and go, and they have intermittent pain. And intermittent pain is one of the big key things. And even though the majority of people in the middle of their flare-up think it's constant, very few times is it constant. Like, it's almost like pulling teeth. I argue with people, do you really have constant pain? Because constant to me means it's like a black or white question, right? You have, from the moment you wake up to the moment you go to bed, you can't even get busy and ignore it. They're like, oh yeah, I can get busy and ignore it, right? Or some people are kind of convinced that it's constant, and I keep on going over. They're like, no, it's constant. I'm like, okay, they're like, oh yeah, it's like a 10 out of 10 right now. Meanwhile, they're actually smiling and having a great conversation with you and joking around. We've all had those patients, and like 5 minutes later, like, I'm like, how do you feel now? And they're like, I feel fine. I'm like, so is it really constant? Because sometimes they have to be convinced that it's constant. So that whole intermittent pain thing tells me that their nervous system can be reset, or it is there are times where it actually feels safe and a neurotag isn't being activated. And then I go on to tell them, hey, look, you have intermittent pain. So you fall into a category of what I call rapid responder. So typically within 4 to 6 visits or so with the right education and the right program, I think you're going to be just fine. And I never say like it's going to be 0 or whatever, but I just say like, if you follow the steps that I give you, and I call them all recovery plans now, I don't call it home exercise program anymore, because a recovery plan is actually like better than giving someone homework, because the connotation behind homework is no one likes to do it. But a recovery plan is like you follow these steps and you recover. It's great, right? So slow responders are the people who maybe they have a loss of plane in all motions, or there's true issues in the tissues, right? If you are immobilized, or if you've had a fracture, or you had a surgery and you've been immobilized for a while, you have a contracture, there's nothing you can do to reset the mobility. So mobility is not going to change rapidly, but you can still change the pain of a slow responder rapidly. Like you can make a frozen shoulder have no pain, but unless you rupture all their true adhesions, you're not going to change that, right? And then the non-responders are typically some variation between slow responder and you're not going to change anything. Maybe you can change their motion, but you're just not going to change their pain. You can only change their function, and they need a whole lot more. And typically they have more than going on than just kind of like stiffness and pain, right? They need a whole lifestyle change, and a lot of comorbidities typically as well need to be addressed.
It's so important as well for new therapists to understand that you can have these, I think you call them kind of the ability to recognize patterns, pattern recognition skills to identify the potential response of the client, and also to kind of have a conversation with the client if they do recognize or if they do state that their pain is constant, and you kind of dig in a little bit deeper and help them understand that it's changeable, that it is intermittent, but they have the capacity to experience no pain. And using that as I know Butler might use that as a sim, sims versus dims, like something that just to generate some kind of safety to the nervous system, that they do have the capacity to experience less pain, is just another way to create a more changeable and more positive environment before you actually begin your treatment as well. So a lot of things can be changed when it comes to changing expectations or just recognizing patterns before you actually begin treatment too. And I think like when I graduated, you're looking for all those techniques, you're looking for all these different strategies to begin treatment straight away, instead of recognizing patterns and understanding how to make this assessment and treatment process the most robust possible, and having the ability to converse with the client as well, and for them to recognize their capacity to change as well is going to be massive going forward.
Right. I think one of the best things we can do is give a patient hope, because so much of what they look at on the internet and so many clinicians that they see give them the opposite of that. And every visit is full of nocebo and bad news. And you'll never do this again. You'll never, if you're a TMJ patient, you'll never eat a salad again. Oh, you got to give up working out, or running is bad for your knees, and all these things, right? And giving a patient hope is probably what the best therapists do, regardless of whatever their approach is. And a lot of it has to do with a lot of soft skills, right? Like that probably can't be taught, but should be taught. Really, like how to interact with someone, how to recognize high fear avoidance. And if you have that, there's no manipulation or tissue technique that's going to actually give someone confidence in their own ability to recover again.
Yeah, that's it. Absolutely. Another thing I wanted to talk to you about as well is, and this is, I'm just picking up on kind of general principles that I noticed with your approach, in that you do a great job of not changing tasks very, very often with the client. Like up in that course in Boston, there was a guy there who had back pain during a squat. You identified the low capacity right versus left in the lumbar spine, and then we began loading one side, the side that didn't have the same kind of low capacity as the other side. After I think it was 10 to 20 reps, there wasn't really much change after the first set, but at that point, it wasn't the case where you just changed the task. You drove more reps into the system. You gave more load to the system. And then after another 10 to 20 reps of the same exercise, you noticed a big jump in terms of pain relief. And then after more reps of the same exercise or the same strategy, you notice even more pain relief. And I think a lot of therapists, especially with this idea of the test retest model now, it's always the case, and everybody understanding more about the nervous system and how because obviously everything is influencing the nervous system, but everyone thinks that when you deliver an input to the system, you should get a very quick, immediate change. But that's not always the case. And it's not a case where if you don't get that quick, immediate change after the first couple of reps of the same strategy, that you need to change strategies, but you might just need to increase the challenge a bit, or to drive more load into the system to actually get the nervous system's attention. Because we always kind of use this statement on our courses with our students, and talk about how you can't just assume that the nervous system is ready to learn from the first couple of inputs, from the first couple of reps of a strategy. Sometimes you need to drive more load into the system and challenge the system a little bit more. And after, I think we went through like 100 reps, almost 100 to 200 reps with this guy. And after that, he was pain-free during a squat from being in back pain. I think it was like an 8 out of 10 in its back, but just using the same strategy to drive load into the nervous system and continue to challenge that strategy, continue to allow his nervous system to learn from that input. Because it takes time for the nervous system to learn as well. And
does.
That's just a big general principle that I noticed. Because I would have thought, Jesus, let's jump to the next task or the next strategy, the next technique. I thought that was brilliant by you not jumping into different tasks.
Right.
That makes sense.
I gotta be a little humble here. Is one, I got that from the McKenzie approach, because typically I've seen them. I mean, I'm really impatient, and I'm thinking right now, I don't really remember that exactly, because it's just like all the patients I've ever treated in courses have all blended together. But I'm thinking myself right now, I'm probably happy. I was probably like greatly relieved that it actually worked. There's nothing like failing right in front of your audience, which I'm sure you guys have done, because it's impossible to have like 100% track record and you pull someone up there who's like actually all full of placebo, right? Like they've seen you help all these other people and they're like, oh yeah, he's just going to do like 10 reps on me. Everything's going to be magical. But if you say that I took 100 reps for him to be pain free, I'm probably like, man, let's just try again. Let's try again. Or there was enough of a change, right? Like something usually tells me to keep loading in the same direction and not immediately abandon it. Like he may have not felt different, but maybe his squat cleaned up a little bit, or maybe his hip mobility improved a little bit. Like something led me to believe that loading strategy was appropriate. It wasn't that we were getting nowhere, right? But yeah, that's the one thing that I also learned, and I've said this to people before too. Like the nervous system is easily tricked, but it's not easily convinced. And when someone has like a very persistent neuro tag, it's basically just like learning anything. Like unless you actually have, I'd be interested to see, is someone who has like a photographic memory, do they actually respond to like manual therapy and resets better too, because they can just learn like that without having to repeat it, right? Like the rest of us. I mean, and that's part of also what I think of as rapid responders is typically they're there. Like maybe you have a reputation for getting people better fast, so they already believe that you can have it done. They're more open-minded. They actually have a growth mindset as opposed to a fixed mindset. There's nothing more difficult than someone who's like, fix me, right? But and they want like all passive care, and that's a very fixed mindset. And as soon as you're like, oh well, even if you feel better after this, you have to do these following things and change these things about your lifestyle and your behaviors. You're like, no, can't you just like scrape it out of me, or just, adjust it back in and all this stuff. So yeah, there is something to be said for repeated loading and also not abandoning it. But there's no easy shortcut for that. But what I would tell you is you are headed in the right direction if you see any minimal change. And you shouldn't exhaust a repeated end range loading strategy until you've actually loaded end range several times. Don't be so quick to retest after a set, unless someone actually has like 9 out of 10 back pain and it's like radiating down to their foot. And maybe after a set, if it's completely centralized, yeah, you can retest. But I think of what something like the FMS and the SFMA tells us is like you immediately retest after like one intervention. That's probably not that realistic, because someone is going to be like, recovery is a balance. And I always say things that trigger or sensitize your system are negative on like a horizontal timeline, and things that reset it or desensitize the system are positive. So it's a balance of those positives and negatives. And someone, might get better with 10 side glides in your office, but when they go back to their office and they haven't done it, they forget to do their hourly resets, and they didn't get up and they didn't hydrate and they got a poor night of sleep before, they might have started like on a -20 on that timeline, versus if they got a better night's sleep, they didn't go into work in the morning because on the day they saw you because they had your appointment anyway, maybe they already started on a +10. So things might affect them differently. And again, there's all those factors that I think kind of also make pain complex. And I know that I am a big fan of pain science, even though I do think that treating people in pain you can get results with very simple assessments and very simple treatments. Even though pain itself is complex as to why it happens, I think that the majority of people can get better using simple assessments and treatments. I don't know if that makes sense. It's complex.
Yeah, no,
it's both complex and simple.
I think in general, as people go through their careers, they realize the more they learn, the more simplistic their approach is, you know. And I think one thing's interesting that I think is important for a lot of people to understand, especially like new grads, but with all these courses now that are around the nervous system, like even your rapid responders, that category is still like up to 6 visits. You know, I think setting that expectation is so important, especially for a lot of people who come to our course, like regarding the nervous system. They always think, because there's other courses out there, it's like, oh, it's like this, right? And then it's this permanent change, etc. And really instilling an appropriate timeline and getting the patient to understand that it's going to take a lot of work on their end, and frequency many times is much more important than intensity, right? So them doing a lot of stuff in those recovery plans on their own is such an important concept to grasp, because like Ryan said, it, the nervous system isn't already always ready to learn, and then it takes convincing, so it takes time. And I think for us, like even at my practice here in DC, people come in and they've heard a story like, oh man, Kyle got this person feeling better after one visit. Like, yes, they started feeling change maybe, but I would never discharge someone then, right? Like it takes time and it takes progressions to be able to make sure they have the load capacity to go back into the uncertainty of the real world. And that's where that fixed mindset of people being on the table and all that hands-on work really starts to falter, right? Because you have this really safe environment. Everyone cares about you in the clinic. Everyone wants to make you feel better. Then as soon as you go back into the real world, you're crossing the street, you almost get hit by a bus, right? You have your boss yelling at you. There's all these uncertain stressors. And unless you have this kind of load capacity and this load tolerance way into that positive end, those negatives are going to add back up really, really quickly. And all of a sudden you're going to start expressing with pain again. So I think that's just a really important thing for people to take away, because I know so many people who come to our courses are always looking for this really quick fix. And sometimes they're a little bit frustrated to hear that, yes, we're working with the nervous system, but there's much more to it than that, right? You're still affecting tissue and you're still working with the body, and that takes time.
Right. I think that setting expectations, I learned the hard way, probably maybe 8 or 9 years ago. I had a patient who I told her was a rapid responder. The majority of people who I'd say that you can even see like, oh, wow, you know, like when I explain what it is, like they're relieved and they really buy into why they have to do these things. I'm like, hey, you know, if I scrape you or do some tissue work or manipulate you or do whatever it is, you might be feeling better now, but it's up to you to keep it, right? And you have to really use these very simple strategies. I'll give you like a 2-step plan to follow for a week or two, and you have to be diligent. Even if you feel great, don't give it up right away, right? Because it's like the dosage is like it's like a prescription, like a Z pack or a steroid pack. It's a high dosage in the beginning, and then you taper off, and you can't do either one of those things, otherwise the infection or the inflammation kind of comes back. And people get that. So this patient was all into it, and they were really compliant, and they came back the next time like a week later, and they had zero change, and they were really compliant. I can just tell, you can tell whether someone's compliant or not. They were able to demonstrate, they had a great attitude about it. And she started crying and saying, well, you said I was a rapid responder and I didn't get any kind of relief from doing it. I did everything you said. And I was just flabbergasted. I mean, I thought for sure it would be a simple case. And a week later, I read this study that basically showed if you're too positive, then that could adversely affect patient outcomes. And I'm like, I'm too positive. And ever since then, I've been like really, and I know clinicians kind of go up and down with the amount of confidence they have, but I've tried to skirt that line of being overly confident in that someone would easily improve. But I also don't want to make them feel like I'm not an expert and that I don't know what I'm doing and I'm too uncertain. So that in itself is a balance of being too certain and uncertain. But that just really affected me so much that I've lent toward uncertain unless it's really a very simple case. And unfortunately, the better of a reputation you have, the more you have on certain difficult cases that may not be able to reset easily.
Yeah, I think it's a case of I think it's nice, it's liberating to manage the uncertainty and to be aware of the uncertainty, right? And that's why I think, not to just bore people, but that's why I think having that framework in place that gives you some level of simplicity in the face of complexity is always important. It allows you to fall back into that framework a lot more.
Right.
And not to go back to that case again, but in that course with the guy with the low back pain, and it's not a case where he didn't have any change after the first set, but he had some change after the second set, which pushed you on to continue with the loading. But it was the fact that we actually did an assessment beforehand, and we identified the difference in low capacity from right to left, and then we made him aware.
I remember
brought
him now.
to his own conclusion, because
I remember him now.
kind of like looking at you like this.
I remember him. Was he a young guy?
Yeah, he
who
was.
had he had like such a bony end feel in his hip flexion and IR. I mean, it was so bone, and that's where everyone started making fun of me. And it wasn't only John Russin. There was like John Russin and Matt Abraham was there. Like it was like an influencer type thing,
Yeah,
because I just invited all these guys. They all just showed up at the same course, and it was really cool. And I was like, man, I'm failing in front of all these cool people. But I remember this guy. I thought I was just like totally bombing, because even though he was feeling better, his hip, and I was cautioning this too. I'm like, I don't think his hip is going to change, because that's where I kept on saying, is it bone or tone? Is it bone or tone? And everyone's like, boner, boner. He's saying boner, because no matter what I did, I loaded his lumbar spine. I think I might have done some corkscrew on his hip with edge bands and stuff. His hip didn't change in flexion and IR. And even though his squat was improving, his pain was improving, his hip didn't change. And I don't remember exactly what I did. I don't know if it was a corkscrew at the end or if it was like a lumbar roll, like really end range loading him lumbar roll, but not for gapping, but for loading. And then his hip changed so much. Like I think he might have had more hip flexion, more IR, and his end feel went from what I thought for sure was bone to firm, what it should be. And I was like, was anyone filming that? Because I didn't film it. And I was so disappointed because I had such a change. Was it that guy? I had such a change, and I really wish someone shot it, but no one shot it.
I'm not sure that was that. I think that was a different guy. This guy was just going through squats, and he was always standing. We did some lumbar loading with him, and that was it. Only
lumbar loading. Must have just been
remember that. I do remember that guy with the change in hip range of motion. I don't think anybody recorded it.
I know, because I was like, man, I thought for sure
expectation on you with all those big influences in the room to show some kind of value, I suppose.
Yeah. Well, I've also had a review from other people who said that, one of the things that I think I liked about the course the best was that when you failed with someone, you just kind of said, you're not going to win them all. And it was like so realistic, as opposed to someone saying, oh yeah, you should, like, everyone is a rapid responder. And that's a red flag, right? Like if any approach tells you you'll be able to treat every single, like if on their bullet list of you'll be able to treat like whiplash associated disorder and fibromyalgia and chronic fatigue syndrome, like every single thing that is difficult, that's probably a course that you might want to steer away from, because no one really has the secret, right?
Yeah, I think it's the same thing for providers. Like I always tell patients all the time, like especially when they're going to like a physician or something like that, advocate for yourself, because if someone is telling you they have all the answers and knows exactly what's going on and tells you exactly the structure and this is that, and big red flags all the way across the board, because no one truly knows every single factor that's influencing what happens. If we did, no one would be in pain, right? Like,
right, yeah.
It's obviously not that simple, right? So I agree 100%. I think you have to take everything that's said with a grain of salt and understand that so much of it still is going to be the individual sitting in front of you, and that's not replicable to be perfectly learned in every scenario, especially at a course. It's really, really challenging.
Yeah.
For sure. Erson, just to get just to get an insight into, because I know obviously early on, people might have recognized you as just a manual therapist, right? But obviously now you're
It's
obviously
an
getting
unfortunate brand of URL
yeah,
that I got, the manualtherapist.com, that people are always shocked when they see me treat live how little manual therapy I do.
yeah. And that's the point, I think, because we always get the question as well, is like this standard question that everyone gets and everybody researches even as well, is that does manual therapy work? And it's just a silly question, because you have to define what you mean by work, you know, and work can mean many different things for many different people.
Yeah.
But again, for you, it's a case of not does it work, but when might it be useful to support the moving in the right direction, the client moving in the right direction. So
Sure.
when
Well, I want to get your guys' take on this too, because man, there's like a big anti-manual therapy sentiment out there, right?
Oh yeah, huge.
Yeah.
And yeah, I mean, we're definitely big advocates of, and again, with manual therapy, there's so many different manual therapy strategies you can use. You know, we definitely have our own kind of approach and manual loading strategies that might be different to just putting your elbow or your thumb through its tissue, or scraping, or putting tape or needling in an area. But in your opinion, and we can definitely share our opinion as well, like when do you think, under what circumstances do you think manual therapy might be useful?
I think there are a couple conditions where I would probably use it almost every time, which aren't a lot of conditions that you see often, like a true lumbar lateral shift with radiculopathy and maybe neuroscience, and is not going to respond to, like loading with weights. I always wonder when someone is like, oh yeah, and they're usually like strength-based physios, and I get it, right? Because exercise and strengthening is probably one of the only evidence-based treatments for every condition in the world. Like, it doesn't matter whatever you have, like everyone needs to load more and strengthen and hypertrophy because it's just better for everything. But when you're so anti-manual therapy, when someone walks in like that with a true lumbar lateral shift, or they have maybe like a true torticollis or something, it's not something that you can just like have someone shrug with weights, or you can't just like have someone has a lateral shift and they have neuroscience, and they're like 1/4 to bend away from wearing Depends, because they have a huge disc herniation. You can't just give someone like a kettlebell and have them do farmers carries. I love farmers carries, but there's a time and place for everything. And I just think you're really limiting yourself when you don't have anything else to fall back on. So when is it appropriate? When a person can't do the loading strategy or the position or the recovery plan that's going to make them better. Like, their nervous system needs some sort of external feedback that they can't give themselves, or maybe they don't trust it themselves. So there's so many danger signs that it needs some sort of novel feedback that a simple position or an end range load can't do. They might need some sort of, they've had an adjustment in the past, so they think that's what's going to fix them. They had great tissue work, they had needling, or they had something in the past, so they've heard that this is going to help them. So only when someone can't end range load or can't get into the position that I think it's going to initially start that reset and that convincing of the nervous system. The nervous system needs a little bit more convincing, and that's basically what I think the manual therapy is for. Now, is there any one technique that I think is better than others? No, because I think they all work for the same reason, right? They're all novel inputs that change in output. But I think that no matter what, if someone actually has a preference, I think you should probably start there. Like, if someone says, oh yeah, I got better with kneeling, or I got better with manipulation or adjustment, you should probably start there, because they already have like a layer of positive placebo laid on top of that technique. So that's when I think it's appropriate. And I'm always quick as soon as someone gets better. I'm like, the only reason why we did this is so you can do the strategy that will keep yourself better. Because unless you want to pay me, like, I'd happily take your money and treat you every hour, several times a day, day after day after day. But if you don't want to pay me or anyone else for the rest of your life, all you have to do is this recovery plan.
Yeah, I think you hit the nail on the head there. It's always, you can recognize as clients that might not be capable of handling active loading strategies even during the subjective assessment. And I think that, yeah, with those clients, you might feel the need to use some manually driven loading initially. But in many cases, again, it's about understanding that you do want to challenge the client actively first to get an idea of their overall load capacity, and then just try and use manual therapy strategies to support their active loading strategies as well. you know. But from our perspective, we tend to use a framework that tries to take advantage of the uncertainty of the environment acting on the system, right? And so the ways in which the environment interacts with your body, where it interacts with the body, like simple concepts like where do you actually directly interact with the environment from a segmental standpoint? And typically it's going to be the endpoints of our limbs. So our hands will interact with the environment directly, our feet will interact with the environment directly. Unless you're obviously sitting down all day long, obviously then your glutes, your pelvis is interacting with the environment. But we try to consider the kinds of loads, like gravitational forces acting on our system. And then we want to understand what kind of influence that is having on the strategies that we might use to manage those forces. So we typically see manual therapy as a way for us to use our hands to mimic the loads of the environment, right? And so what we will do typically from a manual therapy standpoint is use classically what you might think of just manually driven isometric strategies, but it's done from a standpoint of trying to manipulate strategies the client is using to manage internal forces. And so one of the big things from our manual therapy approach is recognizing the organization of tissues from distal to proximal. Like you have a lot more biarticular tissues in your limbs versus proximally versus your midline. You have a much larger distance between the joints in your limbs, between your wrist and your elbow and your shoulder, compared to the carpal bones in your wrist, compared to the joints in your spine, for example. So those biarticular tissues, and in the research as well, a lot of the research will look at the differences between biarticular tissues and monoarticular tissues. Biarticular tissues are more so biased towards transferring forces, being able to dampen stress and dampen errors acting in your system. So what we will typically do is, say, for example, somebody's lacking internal rotation of the shoulder. We'll actually get them into those positions, not necessarily into the barrier, start in the mid-range, but then we'll get them into the position where we're trying to restore what we would call the contractile variability of the biarticular tissue. So we might get somebody into an internally rotated position. We might even internally rotate the distal segment too. So internally rotate the humerus, internally rotate the forearm. So both are internal rotation. And then through the hand, we might we'll change the way that an individual manages internal forces through the tricep, for example. So classically, the difference between like a push versus a hold. If we say to someone, push into my hand, keep pushing like you're fighting me, then it's going to be more concentrically driven behavior in that tricep. If we have them hold there and we're building tension to them and not having them allow us to move them, then it's going to bias more towards eccentric behavior. So from our standpoint, we're trying to restore some variability in tissue behavior, you can say, to give the nervous system a better understanding of how it can tolerate load and trust the capacity of the system to tolerate load. And then we're just moving into different ranges of motion, and we're changing the joint kinematics, but we're loading the system in a very similar way. So that's kind of our sort of thought process. And obviously that's not going to fix everything, you know.
Right.
And I obviously don't like to use
because nothing fixes everything.
Exactly. But it's just a strategy that we use to support our active loading strategies, you know?
Yeah.
And
Every time I hear you guys talk, I always just think, I got to drop in on one of these courses.
You have to.
Because I think I said it, I don't remember when you did the webinar for me, but even after the webinar, I was just like, I think I might have said something like, this is one of the only novel approaches I've come across in a long time, because I've not, and you know, to plug you guys, because you've plugged me enough, thank you very much. I have exhausted what I think are the traditional PT course. It's not like I don't take PT courses. It's that I have not come across anything that has struck me as, wow, this is amazing, or this is really a unique take. Which is why in the past, I've only devoted myself to soft skills and other things like nutrition and mindfulness and sleep and recovery and all those things that I don't want to learn any more PT assessments. I don't want to learn any more hands-on techniques. I don't want to learn how to needle the pelvic floor, because I just stayed away from anything that wasn't level 1. You know, I didn't want anyone needling my pelvic floor. I didn't want to needle anyone else's pelvic floor. I wanted to stay away from the lungs. Like level 1 scared me of all the other of the lung field, even though I know people do it successfully. But every time I hear you guys talk, I just think, wow, that's like such a unique take that I need to have in my brain. So yeah, I will.
We'd be happy to have.
I'll hit you up.
Yeah, we appreciate that. Hopefully, like we said before we went live here, we get some in-person stuff again this summer. But if you ever want us to just give you access to one of the 8-week online cohorts too, let us know.
Right.
And
Yes.
we can certainly do that.
We'll trade.
But
You guys,
yeah, absolutely.
can do my 12-week and I'll do your 8-week.
Cool. So I know we're running up on time here, so I know we did some plugging for you, but why don't you give the people one more chance as a reminder of where they can find you and where they can learn more about what you do.
Sure. Well, if you follow me on, you can follow at Modern Manual Therapy on Instagram, Facebook, or YouTube. So I mostly repost all the same stuff. Also on Twitter as well, _OMPT. So all my stuff, all my offerings, podcasts, sites, blog, everything is at modmt.com/sites. So that is a list of like everything I have to offer, including my podcast, my seminars, online seminars, everything. All my seminars: Modern Manual Therapy, Modern Strength Training, which is BFR, Modern Patient Education, Modern Nutritional Rehab, which is a CNPT program. You can earn that credential as a physical therapist or another clinician, rehab-based clinician in nutrition. And that's all included in Modern Rehab Mastery, which is my 12-week program. But all those courses are also available separately on edgemobilitysystem.com.
Perfect. Yeah, really, really great. Thank you so much for coming on, and anyone who's watching here on the recording, make sure you check them out. And as far as people who haven't been involved with us yet, there are just a couple spots left in this next IKN Approach Level 1 cohort online. Those will probably fill up this week. So if you want to grab up those last couple slots, that cohort starts on March 19th. So go head over to our website so you can make sure you do that. Otherwise, thank you again, Erson, for coming on.